have Dr. Christine Duncan from Boston Children's and Dr. Troy Lund to talk to us about balancing the risks of transplant and gene therapy.
All right. Thank you so much for the opportunity to be here and just globally to be part of your community. It has meant more to me in my career than I can possibly express to you. I think the question that was just asked about how you choose one versus the other, and then also how you navigate those things as far as cost and payers, are extremely important. And I wish that I could say at the end of this next time, we've got lots of time for questions, so that's hopefully Troy and I want to have a conversation. We're not going to be able to say for every family in this room and for every patient what the right answer is, because there's not one right answer. Um, and as an advocate for gene therapy and for stem cell transplant, I think I can quite honestly say they are both very imperfect therapies, and there's still a lot of work for us to do. At the end of the day, these completely imperfect therapies are what we have, and they are better than cerebral ALD. So, not great, but we're still trying to learn and we're still trying to improve. So, I'm not here to say gene therapy is better or stem cell transplant is better. I think what I'm here to say is that I'm so glad that we have options and families have choices, and we need to do our best to make sure that everyone has access to the therapy that is best for their child and for their family. Um, my email is up there. I've seen Troy and others present as well. I know we are all in the community happy to talk with you at any time. That is my office number. I'm happy also to share my cell phone number with anyone who is interested. So please reach out. Um, this is an impossible to read slide for you, but what I want to do is, but it's really nice and I spent some time on it. So I want to walk through a little bit of a history of cerebral ALD, and I'm not cellular therapy. And when I talk about cellular therapy, I mean gene therapy and stem cell transplant. And just to say, we've been doing this in the community for 41 years. And so the first bone marrow transplant was the date about the first bone marrow transplant was published in the 80s. And in red, we see these milestones in stem cell transplant, and that through the 80s, the 90s, and the earliest 2000s, that was the only therapy or the therapeutic option that we had for boys with cerebral ALD. Much of that work, obviously, being led by people in this room and others. And then the story of gene therapy for ALD is much like we just heard. And I actually, Cynthia, thank you for sharing. I was going through those ups and downs with you as you spoke, and all of us who were part of those studies are really indebted to you and your families for what you provided us. But I can say we've treated the first boy on the bluebird studies, or the prior studies, I should say, in 2013. So now we've been doing this for about 10 years. That child is doing well and approaching his 10-year anniversary of treatment. For a very brief period of time, or I guess 5-year period of time, we had lots of highs in the gene therapy world. We enrolled patients relatively rapidly. We enrolled 32 patients on the first study. We published in the New England Journal, and we were feeling great. There was a second study that was then opened in 2018, ALD 104, and enrolled that rapidly as well. And like everything in medicine and life, I guess, as well, there are the ups and downs. And 2021 was a really hard year for us. And I'm going to speak more about these diagnoses in general. And so in 2021, we had 3 patients diagnosed with myelodysplasia following gene therapy. I'm going to talk a little bit more about what that is, but myelodysplasia is a cancer. And these are cancers that were related to the gene therapy and to the process. And so I don't know how everyone else in the community felt, but I wasn't sure that things were going to move forward. And then they did, because we're still faced again with imperfect gene therapy and we're faced with imperfect stem cell transplant and needing to have some options. And so then in 2022, a better year, but still having to think about the challenges for the families and the boys who did not have experiences that we hoped. We had the FDA Advisory Committee, and I know some of you in this room and some of you on Zoom participated in that. And so thank you for that, and received unanimous approval from the FDA committee to support the approval of the product. And then in September, the approval of the product, and as you saw yesterday, the first patient receiving in 2023. There are more patients who are in the process of preparing for gene therapy currently. I know that there are people in this room who could give a stem cell transplant talk equally, if not better, than I can for boys with ALD, but I would like to level set for everyone so that we're on the same page for those in the room and those who are not home, or at home, excuse me. So the therapeutic options for boys with cerebral ALD. And also, as a caveat, I'm not speaking about the boys that Dr. Eichler and others spoke about so importantly yesterday for the boys with advanced cerebral ALD. So these are boys who do not have advanced disease. So right now we have two options, allotransplant or gene therapy. They both have the same goal. Both of their goal is to stop disease progression. Neither of these therapies has been shown to be effective for advanced disease. Neither of the therapies can reverse symptoms that are present at the time of the therapy, and you may progress for months after treatment. Neither of them treat adrenal insufficiency, and at this point, we don't understand the impact on AMN, but right now there's not data to support that these therapies treat AMN. The way we go at it is very similar, but it has some important differences. So an allogeneic stem cell transplant, you need to find a donor. And so just as an aside, and because we have time, and I am a little bit notorious for going down rabbit holes, and Troy, I won't take all of your time, I just want to talk about why we're talking about blood therapies for neurologic disease. I don't know if you're first to this world, like, why does this even work? What are we talking about? Because what a stem cell transplant, or stem cell we're talking about, is a baby cell, basically, that lives within your marrow. And that cell can turn into all of the different cells of your blood-forming system. So the platelets, the sticky stuff that help you clot when you bleed, the immune cells that help you fight viruses that we've all learned about so much more recently, or other infections. And they also make the cells, the red blood cells that carry your blood. But one type of those cells, this pretty amazing process, can actually migrate into different parts of your body and differentiate or change into or mature into different types of cells. And one of those, the macrophage, the microglia, can help support microglia. So it's incredible, and I'm still amazed by this, that cells in your body, from your blood, in your bone marrow, when you break up in a bone, that little hole in the middle, can actually treat a neurologic disease. It's pretty incredible. So in both of these therapies, we need to get you some healthy stem cells. And so in the case of allotransplant, your donor is another person. That patient then, the stem cells are collected, depending on how you do your cells, whether it's another person or cord blood or however you do it, the patient gets chemotherapy. Why are we giving people chemotherapy? Your children don't have cancer, you don't have cancer, but why are we doing this? We're doing this to make space at one point, so it sounds a little crazy, but you need to have a spot for these cells once they go in your body to find a home and to grow. So part of the reason is to clean out your marrow to give space. For a stem cell transplant, compared different than gene therapy, you also need to get rid of your immune fighting cells of the person getting it, then can reject those new cells coming in. So that's the whole purpose. We all wish we could do this without chemotherapy. None of us want to be giving children who don't have cancer chemotherapy. And the community is still trying to find a better way, but we're not there yet. After the chemotherapy is given, the stem cells are infused, and we've seen pictures of what that looks like in that experience. It looks like a transfusion of a blood product. Those stem cells that are engraft, and then hopefully engraft and differentiate into the cerebral microglia that express the ALD protein. The general process is different for boys who undergo ALD gene therapy, but has many similarities. In this case, the patient is their own donor, and this is an important consideration. We can find donors for many people, stem cell donors for many people in the world, in the country, but not for everyone. And there are certain populations that we have more or less success in finding donors. I didn't show it in this talk, but one of the things that we see in the National Marrow Donor Program and publishes data showing if you are white of Western European ancestry, we can generally find a donor for about 80% of people. For if you are not that, if you are anything, that drops to about 50% or lower for all other ethnic and racial groups. So there are lots of reasons to think about why we need to have alternative sources for people who don't have donors. So in gene therapy, the patient is their own donor. They go through stem cell collection, and we just saw what that looks like. The patient receives shots underneath their skin to help make your body make more stem cells. So we need a lot of these cells, and your stem cells live within your bone marrow. They're not floating around in your blood circulation. And so once you get those shots, you make more of those cells, and then they get released for collection. The cells undergo a process called transduction, which I'll talk about in just a moment. And then you go through myeloablative chemotherapy and get the stem cell infusion, but this time with your own genetically modified stem cells. So another thing just to talk about a little bit in this process is what happens to the cells after they are collected. So we call this ex vivo, which means it's happening outside the body, stem cells. So the stem cells are collected, and they're collected from the patient, and then my dividing line, let's see if I can get my they're taken to a laboratory. This is a central laboratory. After the collection, the patient is discharged from the hospital, and the cells go to a laboratory where a modified HIV virus, a vector, I'll talk about that in a moment because I know that gives people pause, is combined with what we call the transgene. And this is a healthy ALD gene. So that the vector carrying this gene is combined with the patient's own stem cells, and now you have the patient's stem cells carrying a healthy gene. Just a comment about HIV, because if you've not heard a gene therapy talk before, it's a little bit of a showstopper to say that we're using HIV and giving that to people and to their children. So the HIV is a very good virus for some things, and it's part of what makes it so difficult to treat people who are infected with it. It gets into your cells. As your cells divide, it is still there. So it's a really good vehicle, if you will, for carrying things. But it can also obviously make you incredibly sick. HIV, just a little piece of trivia, has 9 genes, total 9 genes, 9 pieces of genetic material in the entire virus. When it's used for a vector, you can get rid of 6 of those. You can get rid of 6 of the genes that make you sick, that give it the ability to divide and to replicate in your body, and just keep the good stuff. It reminds me, I'm not sure if anyone, this is definitely showing age, but you take the good, you take the bad, and you keep them both, thinking about it, a song from the 80s, and then you have a vector. And so what you need to do, so you don't get HIV from this process, you can't get HIV infection or illness from this process because it's a genetically modified, it's a changed virus. I know that still causes people concern, and that's why we always have those conversations. So now you have the product. You have a stem cell that has a corrected gene, and that's reintroduced into the patient after they have received chemotherapy. So to kick off our conversation about decision making and other things, I just want to give a little primer on some of the terminology I'm going to be talking about today. And these are related to the Bluebird Bio-sponsored studies that were performed at my center, Minnesota, many other centers throughout the country and the world. So you may have heard us talk about Lenti-D, you may have heard about Elicell, you may have heard about Skysona. These are, when I'm talking about this in this presentation, these are all names that were given to this ALD gene therapy product at different points in the development. So if you see one of them, we're talking about the same thing the whole time. You'll often hear people talk about ALD 102 and ALD 104. These are just the easier way to talk about titles of studies that had really long names that were just abbreviated down to the data. Or to the shortened name. ALD 103, I'll talk more about this study. This was a retrospective and partially retrospective and prospective study, so looking backwards, looking forwards, study of boys who received allo transplant at the same time. When we do studies, we have to find a way to put this into context. And so we have to, how is gene therapy successful? We need to be able to compare it to something else. In MFDs, major functional disabilities, I know that you're well versed in this, but the reason I'm defining it here is because I just want to define what the major functional disabilities were in regards to these studies. So in this study, if you developed loss of communication, the need for tube feeding, cortical blindness, total incontinence, wheelchair dependence, or complete loss of voluntary movement, those for the study purposes were considered MFDs. Obviously, there are many other disabilities and things that affect people's lives. So this is the gene therapy portfolio that led to the FDA approval. We often think a lot about the 2 big studies. So when we say prospective, meaning people are getting this and we're following them forward, single arm, we're not comparing gene therapy to not gene therapy in these studies. Multi-center, performed at lots of different places, gene therapy. So we think about these studies. One of the things that's challenging, and you know this very well when studying rare diseases, is that we can't take thousands of people and randomize one person to get one therapy and one person to get the other therapy. That's not practical, and it may not even be ethical in some circumstances. So to try to determine whether something is successful, you oftentimes need to compare it to the alternative therapy in a different way. And so in these studies, we had the first one. And so this is a retrospective, looking backwards, chart review of people who had received allotransplant at multiple different centers prior to the development of these therapies. So the data from those outcomes from transplant, were used to help us figure out what is important and what is success in gene therapy. Then the second, so with conversations, some of these patients who were in this trial had been treated a long time ago. And so to compare to a more contemporary cohort, people who are getting transplanted at the same time, this is what's called ALD 103. And so this was an observational trial. We weren't intervening in these patients, but these were patients who were having allotransplant around the same time that the gene therapy was open. So we could try to compare how the patients did. So this provided sort of more contemporaneous cohort. And then up front, where all of the patients are right now, or all of the patients are in long-term follow-up. So any gene therapy for any disease in the United States is required to follow patients for 15 years after treatment. And that's because we're still learning about these therapies, still learning about risks. And so you are offered enrollment on the study afterwards. And so that's where the majority of the patients are currently. So all of this together led to the FDA approval of the product. So, in this slide, I just want to highlight these are some of the inclusion or exclusion criteria. So, things that you needed to have or not have to be enrolled in the studies. This is not an exhaustive list, but I just wanted to highlight some of them so you knew which patient populations we were talking about. And also because these inclusion criteria very much sort of predicted what the FDA approval would be. The FDA approval for this product is very similar to what was allowed in the trial. So, in the trials, patients had to have a less score between 0.5 and 9, so you could be up to 9. You could not be over 9. You had to have the presence of gadolinium contrast enhancement on the MRI, an NFS score of less than 1, and age less than 17 years. The inclusion criteria, you could not have received a prior allotransplant or prior gene therapy. You could have used statins, Lorenzo's oil, or other dietary modifications in the past, but you couldn't use them. You had to stop those at the time you were enrolled. You could not have received another investigational product within 3 months if it was felt that that product could possibly impact your outcomes. Basic sort of things, you couldn't have clinically significant infection, organ function, other things, but just to say that adrenal insufficiency obviously didn't count as an organ dysfunction. That's an expectation for disease. And for the first trial, you couldn't have an HLA-matched donor, a relative, I should say, who could serve as an appropriate donor for transplant. So in the second trial, that was removed. And just to say what has happened with the FDA's approved label is that there's no mention of donor. So it's up to the treating patient, the patient, the family, providers, and the caregivers to decide if that's appropriate. So the FDA and the approved product doesn't say whether you can have it with a label or not. I'm sorry, with a donor or not. So where are we now with this gene therapy process? And I'm going back and forth a little bit between what's approved and where we are currently. And so this is Skysona. So Skysona is the name of the approved drug product and how the process generally works. So the patient is referred, and as we all know, those referrals can come from all sorts of places. You're a very strong community. People can advocate for themselves. It can come from neurologists, from endocrinologists, other people. It's given to the center, one of the treatment centers. We have a clinical review of the MRI to make sure that the patient, in fact, is appropriate for therapy, neurologic status, gene therapy, VLCFA results. And generally, we perform a teleconference. Obviously, if you live in Minneapolis, if you live in Boston, we're probably going to see you in person, but I don't think any of us are going to ask you to fly across the country the first day. We're happy if you do that, but you don't have to. So most of us are willing to have that conversation remotely. This looks just like the study. So patients undergo the stem cell collection. Usually takes about a week, but sometimes you need to do labs or other things, or you always have to do labs ahead of time. Those cells are sent for that same manufacturing. You get the conditioning chemotherapy. I say 1 week here just as an average. The FDA label does not say what conditioning you have to use. So if you're treated at different gene therapy centers, you may have a different chemotherapy regimen. You're hospitalized for about 3 to 5 weeks after the infusion. If it's all successful, the cells travel to the brain, and you are followed up under long-term follow-up. And this is obviously the ideal situation. We know that it doesn't always work out perfectly for everyone. With the FDA approval, our goal, at least I know at our center and I think others, is to try to do as much remote follow-up as possible. This is all very disruptive to your lives. And as we'll talk about in a little bit, it's not available outside the United States. So for patients who are traveling internationally and otherwise, we're trying to be able to find ways to keep them at home if we can. So now just some data from the study. In these, I'm going to highlight a little bit. So these are the first 2 gene therapy studies. So 32 patients in the first one, 23 patients in the second. And this is data that had been last released in March 2021. Obviously, it has matured since that time, and we're hoping to have updated data soon. And this is the matched cohort. So these are the allo patients who would have met criteria for participation in the gene therapy study. One of the things that could make it difficult to compare is if you found that patients who were getting allo transplants were more advanced, had differences in their disease. So this cohort that I'm going to show is the matched cohort. So the ages at informed consent, 6, 7, 7, so very similar. The less scores, a little bit higher in the matched in the stem cell transplant population, so 2, 2, and 3. The NFS scores, of course, they were 0 to 1 because you had to be that to be enrolled in the trial. All of them had gadolinium contrast enhancement, and follow-up has varied. As I said, this is data, older data, but the first patient was treated about 10 years ago on the first trial. And so this is an important study. An important slide, and this shows our outcomes as far as major functional disability-free survival in the cohort. And so 91% of the patients, and this is in the first gene therapy trial, this doesn't include patients from the second. The reason the patients from the second are included is because they weren't enough that were followed for 2 years at the time this data was collected. So this will be updated soon. And so if your child is not included in this slide or this does not ring true to you, we are always learning, we're always updating this. So the top line is the patients who received gene therapy, and the bottom line are the patients who were matched in that population who received an allogeneic transplant. And so in these studies, 91% of the patients who received gene therapy had major functional disability-free survival at 2 years, compared to 76% of the patients who received an allogeneic transplant. So important things, we've listed the MFDs here. There were this is ALD 102, so the first study, so 3 patients who didn't make that major functional disability free survival endpoint. 1 of the patients died, and 2 were withdrawn to undergo allo transplant. In ALD 103, so the stem cell transplant population, there were 3 deaths and 5 patients who underwent allo transplant. And then I'm going to talk about the 3 cases of myelodysplasia. Interestingly and importantly, there wasn't a difference or statistical difference in overall survival. So that previous slide I showed you was about disability or major functional disability-free survival. This slide is just overall survival, so whether you're alive or not. At 2 years, between allo transplant and gene therapy, the overall survival was not different. So 97% of patients in ALD 102 gene therapy and 93% in the stem cell transplant. Although I'm very much looking forward to seeing, or very curious to see how things go as we look further out. So I think the important thing is that we're still going to learn and try to understand about patients. This is data that we're thinking about and trying to understand. And so these are called box whisker plots. And so this is the average and the range. In the blue are the MRI, the change from baseline in the MRI in patients in the blue boxes who were treated on the gene therapy trial, and in the grayish boxes, those who received allo transplant. And so the less scores were significantly higher in the ALD 102 population, so the gene therapy population, compared to the stem cell transplant population at 24 and 36 months. So this is an important finding that we have to follow long term to determine the durability of therapy. But interestingly, the neurologic function scores were not different between gene therapy or stem cell transplant. So we're seeing differences in the MRI that at least at these points had not translated into differences in neurologic function. So I think this is definitely a more to come sort of slide. And as far as safety and tolerability, so these are just pared down some very basics of importance of safety. So, and this is why these slides and the ones coming up are why it's so hard to decide what is right for who, and that there's no easy answer. So in the gene therapy studies, there were no transplant-related deaths during the period of time we received a transplant. There was no graft versus host disease, so we didn't talk much about graft versus host disease here, but it's an immune reaction where the cells from your donor in an allogeneic transplant can attack the body of the person who's getting it. And that can be minor, sort of a rash you treat with topical hydrocortisone, or that in itself can be severe and life-threatening. That's not a risk when you use your own stem cells. And personally, I think probably one of the most important reasons to consider gene therapy. There was no acute graft failure as described by the study, so the cell's not growing initially in the body. When we look at, these are called grade 3, so more serious adverse events. Almost all of them, it looks like the population in the stem cell transplant was bigger or longer. But quite honestly, both of these are the kind of things that you see with anyone getting chemotherapy. So I wouldn't consider that to be a significant difference favoring either gene therapy or stem cell transplant. And the four cases, I should say, that are really weigh heavily on all of us, or at least in this data, and of course what we've just heard about the case. There's a case of a patient who had transverse myelitis, so a spinal cord change following gene therapy, and we don't know exactly why this happened. It is not clear whether it was related to gene therapy, whether it was related to infection, or how those things overlap. And so that we've not been able, still now, years later, to determine the cause of that, and 3 cases of myelodysplasia. So, what is myelodysplasia? What is myelodysplastic syndrome? So, this is a cancer. You will hear some people call it a precancer or before you get leukemia, but it by definition is actually a cancer. And this is of the blood stem cells, and this interferes with the normal production of stem cells or blood cells within the body. It comes in different varieties and it can affect different types of blood cells. We find this by looking at blood counts, sort of like complete blood counts or CBCs. You can look at this by looking into the bone marrow. And after gene therapy, every single patient is screened for this in one way or another. There are certain safety analyses or studies that every single patient has, and every patient should have. During COVID, I commend every family who showed up and tried because it's so important that we find these things early. And so after gene therapy, you can develop this, and this was known for gene therapy. It happened with other diseases in the past. This is a known risk. And here is the hard part. If you develop MDS after gene therapy, you need to have a stem cell transplant, an allo stem cell transplant. Very busy slide, but just to say more detail about this, because I think it is important that we are balanced and present the good and the bad. So in 2021, the FDA put a hold on the trials. All the patients had actually already been treated on the trials at that point in time, but they were still in their long-term follow-up. I know that there were patients who were treated on single patient studies outside of the trials, patients who didn't have donors, but that's a different conversation. And so for 2 of the patients, they developed around the same time, and they were very short after their transplants. And so the diagnosis happened at 14 months and at 25 months. But when we looked at some of that safety testing, there were some early signals. And so those boys were getting watched very closely until that diagnosis was made. So this was a second trial really quickly after treatment. And so that, I think we were thinking one way about that. There's something about the second trial. There's something when it happens early. And then another shoe dropped in that there was a patient who was one of the very first patients who were treated on the original study, 7.5 years after his therapy, had this develop. And so these diagnoses were made on blood counts, and some of them, their blood counts were actually not that dramatically changed, but because they were undergoing screening, we saw these signals early and were able to do bone marrows and follow them closely. And so why do we think this is related to gene therapy? We think it's where the genes were placed and that they may have turned on, turned off genes that are affected the function of cells that are related to cancer. So I'm just going to do a quick side. And so to understand how you can get cancers from gene therapy, because I think we've all heard that you can get cancers from chemotherapy, you can get different things, but how does this actually happen? I'm going to ask you to just go on a little journey with me through something we call insertional mutagenesis. That sounds really bad, but that's actually what we want. Like, we're making mutants in the genes when we're trying to do gene therapy. So this is a phenomenon by which exogenous DNA, so genetic material coming from someone else, gets into the genome or the genetic material of the cells of the person getting the treatment. So here we've got, all right, you can see I do not have a degree in graphic design or visual representation. So the genetic material of a patient with ALD. So here's the gene, and it's making an ALD protein that doesn't have healthy function. So you insert the healthy gene in gene therapy, and now we have a mutation. And in this case, this is the mutation that we wanted. So we've made this mutation, and you have a healthy an ALD protein, I should say with healthy function, excuse me, and that's the healthy mutation. That's what we want. And so, but what happens is something called semi-random gene insertion. You say, what? And so in this case, so we all know ALD is an X-linked disease. This is a phenomenon involving the X chromosome. But when this gene gets inserted, it can go anywhere. It doesn't have to be in the X chromosome. It gets put anywhere, and as long as it makes that protein, that's all right. Like there are some preferences for different spots within genes, but it can go to any of these chromosomes. And I should have oriented. So this is a picture of your chromosomes within your body. So if it's inserting any of these places, with the current therapy, we can't control exactly where it's going. And so not good is something called insertional oncogenesis. So this is sort of the dark side of insertional mutagenesis. And so if in that random integration where it's putting it somewhere, it puts it near a gene. So in this case, here's your patient with ALD's gene, this genetic material, so the new healthy gene's inserted. And what if right next door to where this is, or somewhere nearby, happens to be something we call an oncogene? And an oncogene is when you turn that on, it can increase your risk of getting cancer. Or, better named, something called a tumor suppressor gene that when it's active helps prevent the development of cancer. If you turn that off, so you turn that switch off, then you can have an increased risk of cancer. And so what can happen is if this gene, if your healthy gene, your ALD gene, gets inserted by one of these places, it can lead to the development of cancer. And so that is basically what we think happened in these cases. And so what to do about that? That's the problem. So there is no way with our current, in the current product that we know how to prevent that risk. We know how to screen, and screening is critical. And so patients have routine counts. Anyone who's here whose child had gene therapy, anyone who's watching us virtually has gene therapy, knows that we see you a lot. So you have CBCs, you have gene therapy specific screening that tells us whether the gene is still there and still functional. You have it that tells us whether you have any HIV, and of course, as we talked about, you don't, but we still look. And you have testing that tells us, gives us a map of where that gene was placed. And if we see in that map there's one spot that's growing over time, we start to think about it, and we'll bring you back, and you'll have more studies, and you'll have more tests done, and we will watch you. So the other things is that we're still thinking about this and what to do. So while we are proud of this product, this is an imperfect product. So we're still thinking about different ways to do different gene therapy. So using a different vector. So the vector is the machinery, the truck that's bringing that gene in. Maybe we need to change our truck. And so if we change that and do a different vector, there are ways you can decrease the risk of this. And so people are looking at that. People are thinking about that. There's something called gene editing, which is where you go to a specific spot to change a gene. And that's something that we're all thinking about too and can turn to do this work. So the story's not over with ALD gene therapy. There's lots of work to be done, and there are people who are still doing it. So that's my MDS, and I'm happy to talk with you more about it. So just getting back to some of the data from the study, and Cynthia shared this with us already. You're in the hospital a different amount of time with both of those. And so this is based on the data. So in the gene therapy trial, looking at 66 patients compared to looking at 47 patients who received allotransplant, you're in the hospital median, sort of the middle amount of time, 28 days for gene therapy compared to 52 days for allotransplant, with huge ranges across both. So a range of 15 to 59 days with gene therapy and 25 to 240 days in patients who received allo. And as people who've been through allotransplant, you know there are lots of ups and downs. And afterwards, you're expected to have shorter contact restrictions after allotransplant because you're on immune suppressing medications, because your immune system is still recovering. You're limited in the places that you can go, where you can be interacting with the world. Different centers have slightly different regulations. So if you're talking to all of us and trying to figure out where to go, if that's important to you, ask about what the restriction plan is. After auto gene therapy, it's shorter. It's shorter by a magnitude of months than it is after allotransplant. And just to speak a little bit more about commercialization and where we are now. So you've heard that we received approval in 2022, and it's offered at a growing number of sites. So we're excited to have 3 places now that are able to offer therapy, and hoping to have the other on board soon. First infusion, you saw, happened yesterday. Another patient has completed their collection and is going to be treated soon. So now the pipeline has started. So the challenges about this, there's no way of getting around this. This is a high-cost therapy. We all know this is an incredibly expensive therapy, and coverage is challenging. But it can be achieved. And we have started this process at our center. I imagine other centers have as well, of working with insurance companies, including some of the state-based Medicaid programs, to try to make sure that every child who is eligible for this therapy, who needs this therapy, can get it. But it takes a long time. And each of the centers, I can only speak for our center. I can say that we have a team of 5 people whose entire focus is to try to help families get through this piece. So you can work with My Bluebird support, but also the hospitals have to work with every single insurance company, because even though it's improved, the insurance company may not approve exactly what the FDA said. They may decide where you could get your therapy, or what they're going to pay for. And so there's just a lot of, quite honestly, intense financial advocacy, but it's out there, and people are very much dedicated to getting people this therapy if they need it. One of the things that I struggle with is the global access. So this is only available within the United States. And on those gene therapy trials, we don't have the numbers here. Patients participated from all over the world. And right now, it's very challenging for patients for other countries to get this, due in part to travel and other things, but also because of the cost. And so, as a community, I think we need to think about how to support patients internationally who need this therapy. And then the time to treatment is something else I think part of our conversation we can talk about. Depending on your donor availability, you may be able to get to an allotransplant quite quickly. Um, After your stem cells are collected, the time range can be as long as 8 to 10 weeks from getting those cells back in. And so that may mean, even though you're eligible to get gene therapy, if you have a less score less than 9, maybe if you're in those higher ranges, it might not be the right thing for you if you're going to continue to progress during that period of time. So these are, I realize now I seem quite negative about both of these therapies. They're all still amazing. It's still incredible that we are able to do these things, but there are difficult outcomes. These are challenging situations, and these are intense therapies. And so you have to balance these things. So on the side of gene therapy, what's good for it? No graft versus host disease, no immune suppression, no need to find a donor, generally shorter hospitalization post-transplant care. It may take longer to treat depending on what your particular situation is. And we are learning about the long-term risks. And so we can talk about how we've been doing transplant for 41 years. We're still learning about gene therapy. And so whether it's the immune process that you just heard about or the myelodysplasia, we're still learning. Even 10 years into therapy, we're still learning. And the high upfront costs. On the side of allotransplant, graft versus host disease can be life-threatening. And if it's not life-threatening, if it doesn't kill you, it can really hurt you, and it can cause significant mental health as well as social health implications. The greater risk of graft failure, greater risk of death up front, but it's a known treatment. And we have to figure out what the cost options are. So whether you have, so in the part that you can't put in this is this is the patients, this is the family. Everyone who comes to talk about cellular therapy comes from a different journey. Often with a lot of trauma, often with a lot of experience, or people who have just gotten a new diagnosis and it's terrifying. You are a voice. You have a voice. You are the most important voice in this conversation. If you've decided allo is right for your family, then our community supports you. If you've decided gene therapy is right and you're not sure you're going to get it covered, we're going to fight for you. So that is important. So we have to decide. And I know Troy's going to talk in just a moment if I ever get off the stage. Sorry, Troy. About sort of the factors and how we manage these decisions. So just to end, I want to thank sort of an insufficient number of people. First and foremost, thank you to everyone in the ALD community. Personally, I want to thank the families who entrusted the care of their children to our teams. It's really remarkable, and it is humbling, and it is a responsibility that we all take with utmost seriousness. And we share your joys, and we share your pains as much as we possibly can, and all of your families. And then I also want to send, I call this my iceberg slide, because this is totally insufficient. So these are the people I want to think about. This is our Boston ALD cellular therapy team, with my huge gratitude to Florian, who brought me along or started me on this journey. And these are some of our members of our medical team, our research team. And then the important things when we think about centers, this is our staff psychiatrist, Dr. Wishart, who is a rehabilitation or physiatrist. We have a school liaison program, and all of these people. So we could not make any of this work without you and without all of these people. And I know that every center that you're looking at has these supports. So we're all there to support you completely. Thank you. And maybe, Troy, do you want to save questions for the end, maybe? Sure, okay.
All right, well, thank you for the invitation. I think you'll see my talk nicely dovetails with Christy, though I'm going to break mine down to be much simpler. And it's really geared toward the families. We're going to talk about Yeah, the question was asked earlier, how do I make this decision? And so I'm going to go through the process of kind of how we make this decision, and that's the physician and the family together, and we'll see if we can learn something from it. Okay. So back to basics is really the talk. So how do we possibly choose between two therapies, even, or do we have the choice? And what do we know about each of the therapies? And so that's what I'll show you. All right, so who's eligible for transplant? That's pretty easy. On the allogeneic side, it's anyone with progressive cerebral disease. On the gene therapy, as long as they're not too advanced. On the gene therapy side, it's ages 4 to 17 with early active cerebral disease, i.e. gadolinium enhancement. So we use these words transplant, cell transplant, BMT all the time. They're all transplants. They're all BMTs. So hematopoietic stem cell transplant is the same as a BMT. The allogeneic form of the transplants, when the cells are from someone else. The autologous form is when the cells are from the own patient. So on the allogeneic side, you can have related or unrelated transplants. Related transplants includes siblings of the patient, brother or sister, or haplotransplant, which is generally a mother, a father, an aunt, an uncle, someone closely related. The stem cell sources in that case can be cord blood, bone marrow, peripheral blood, and you can have all the different mixes as matches. On the unrelated side, that's a matched person, and the stem cell sources can be cord blood, it could be bone marrow, or peripheral blood. So again, allogeneic transplant, we have our three sources, cord blood, marrow, peripheral blood stem cells. And we know all the cells that are harvested or saved have the ABCD1 gene, and they're all correct. On the day of transplant, all those cells are infused after chemotherapy, and then the patient recovers over the next 4 or 5 weeks in the hospital. So gene therapy, as I said, it's an autologous transplant. It's also a bone marrow transplant. All these terms can be mixed and matched, though I understand if you're telling me there's a BMT and there's gene therapy, I kind of understand that you're drawing a difference between the two, but in fact they are all bone marrow transplants. So as Christy nicely showed, how does the gene therapy process work? You collect mobilized cells from the peripheral blood from the patient. You isolate those cells, they go to a lab. They are then infected with a virus, and the virus contains a normal copy of the ABCD1 gene. What I point out to families is that, in fact, not all the cells are corrected. Only about 15 to 40% of the cells can be corrected. The remainder of the cells, they're the regular old mutated cells. They are not corrected cells. The entire product, both corrected and uncorrected, are infused in the patient. And then the patient recovers in the hospital for the next 3 to 4 weeks. I think this is always a very important point of distinction to point out to families, because most of them don't realize how this process works and what it actually generates. Gene therapy is not gene editing, as Christy pointed out. Gene editing is a new technology where you can go in and you can actually remove the mutated base pair in the genome and fix it with a normal base pair. That is not what we're talking about today. This is a new technology. Maybe it'll find a place in the future, but we're kind of far away from it in terms of ALD. So what about this HLA match thing? What is that all about? HLA are proteins on the surface of all cells in your body. Your immune system uses these proteins to recognize if it's you or if it's somebody else. We determine what these proteins are by sequence, and we use that information to match patients to donors. And the donors could be cord blood, could be marrow, could be peripheral blood. Here's an actual HLA report. So an HLA protein here is designated A0301. That's one protein. There's another protein called A2402, one from mom, one from dad. There's a ton of HLA proteins. There's literally hundreds of them. And all the different combinations make up probably more than hundreds, probably 3,000 different combinations. This is the potential donor down here and their report. They have A03, but In this case, the letter code designation has been used just to make my life more fun. So you dig through this report, then you go to the next page. Here's your code translations. So we saw the earlier one, ANKG could be 0301. This is in fact a statistical probability of it being 0301. And so then we go on more pages of the HLA report. If this is a cord blood, you get a report that looks like this, except it's much thicker. And I get ABO typing, weight of the baby, HLA typing, cord blood volume, how many bags, the cell count, the stem cell count, any culturing, racial information, etc. So you get all this information. All right, so let's go back to transplant is not a transplant. So now we have all the different sources. You have different matching levels. You could have a 6 of 8 cord, a 7 of 8 cord, an 8 of 8 cord. You have these various donor sources. They're all transplants. You can have bone marrow sources from a sibling. You can have a haplo. You can have various levels of matching, 8 of 10, 9 of 10, 10 of 10. Again, all transplants. Finally, peripheral blood stem cells. You could do it from a sib. You could do haplo. Different levels matching again. These are all transplants. I've probably shown you 15 permutations on transplant. And then gene therapy, peripheral blood stem cells. We talked about how the gene therapy is manufactured, also a transplant. What about protocols? So the protocols are the chemotherapy. It's the drug, the timing, the dose. And so one protocol might look like this: drug A, B, and C given on these days prior to transplant, which is the star here, in this order. Another center might use a cord blood protocol using DEF on these days prior to the transplant. And so protocols are very, very specific. They're usually driven by the center's history, their success, sometimes from data within the lab to try to derive the best protocol. Now, looking at gene therapy, all sites use the same protocol during the gene therapy trials, though the ALD-102 trial is different than the ALD-104 trial. But now it's a commercial product. Centers are free to adjust the protocol as they see fit to optimize the best outcomes for the ALD patients. So for example, Center A might have this protocol, A, B, and C drugs, this kind of timing prior to transplant. Another center might do D, E, and F, these drugs and doses prior to transplant. So far we talked about allogeneic transplants, autologous transplants, donors related, unrelated, or self, the stem cell type, cord blood, bone marrow, peripheral blood stem cell, and the protocols, which is the chemotherapy, the specific drugs, the timing, and the doses. So, which is the best option? I get a phone call or email just like this every few days. Dr. Lund, what should we do? 7 of 8 cord blood, large stem cell dose, unrelated female donor, 9 of 10 match, seems pretty good. Haplotransplant, gene therapy. Christy, what should you pick? It's literally impossible to answer this question because I just showed you the complexity of HLA typing and matching and the volumes of paper I have to go through to understand what the best option might be. And so that's why it's very difficult to answer this kind of questions, like what's the best therapy? Well, it depends. All right, so let's talk about what does it depend on. It depends on a lot of things, not just the big packet of HLA information about the donors, but also the age of the patient. It depends on the age of the donor, the disease status of the patient, what their LES score is, the gadolinium status of the patient matters. The rate of disease progression, if we know that. Donor availability matters a lot. Biomarkers, we focus a lot on this in my lab, on CSF total protein, chitotriosidase, etc. Depends on your insurance. Some carriers cover different forms of transplant in different centers in different states. And then the center and the protocol availability. For instance, not all centers actually offer cord blood transplants. Not all centers offer gene therapy transplants. And I'm pleased to announce that, as was mentioned earlier, my center is an activated qualified treatment center for gene therapy, which we'll be able to offer to patients. All right, so more consideration for how to make this decision. Informed consent is key to all of this. And so it's the process in which patients are given important information, including possible risks and benefits about a procedure, genetic testing, or a clinical trial. So here are the things I often hit upon with families when discussing both options in clinic, and it does take some time. Talk about the cells. In the allogeneic setting, the cells are 100% gene corrected. In the gene therapy cells, at best, we get about 15 to 40% of the cells corrected. That may matter to some families, or it may not. GVHD, as Christine nicely mentioned, GVHD happens when the cells from the donor attack the host. It can be acute, it can be chronic, it can be mild, and it can be severe. Certainly some boys with ALD have died from GVHD. Many boys with ALD have been treated with GVHD just with steroids alone, often in the form of a cream, and they're doing well. On our current metabolic protocol, the GVHD rate is roughly 10 to 15%. Most of that GVHD is in the form of a skin rash, and 90% of it is treated with topical creams. You can't get GVHD in gene therapy. It's your own cells. And even in any other transplant where you've used autologous cells, I've never seen gene therapy, or I've never seen GVHD. What about graft failure or engraftment? So graft failure happens when the new cells just don't take. They don't reconstitute the immune system, or they just fade away. The most common treatment for graft failure is unfortunately going to a second transplant. It's a serious but uncommon risk that we talk about. The data I have in the allogeneic setting, it's maybe about 5%. It might be lower now to about 3%. In the gene therapy, there is one child that autologously recovered and lost their gene therapy product. And Christy spent some time talking about myelodysplastic syndrome. And so just to reiterate, August 2021, Bluebird announced that there was a report of myelodysplastic syndrome. It's a blood cancer, as Christy said, in a patient treated with gene therapy. This is a life-threatening complication of gene therapy, and as she mentioned, the most common treatment for MDS in any setting is unfortunately another transplant. So more on myelodysplastic syndrome. You should know 3 patients who've received gene therapy have developed NDS and underwent a second allogeneic transplant. There are also an undisclosed number of patients who are now subjects at risk because they have oligoclonality in their blood, and this is a blood marker for MDS. And so those patients need to be watched very closely for the development of MDS. We don't see this in the allogeneic setting. And that's probably due to the insertional mutagenesis that Christy went through. And again, on the gene therapy side, 3 cases, plus an undisclosed number of patients who are being investigated. What about progression, NFS, MFDs? So we use the neurologic function scale, which is a scale of 0 to 25 of basically neurologic deficits with points scored. And then we have the MFDs, which are really just the most important life-affecting areas of the neurologic function scale, which I'll show you. So regarding NFS, an undisclosed number of gene therapy patients have shown disease progression per the study definition, which is an increase of NFS by 3 points or more. In addition, there's an undisclosed number of patients who have shown an increase of NFS of 1 or 2 points. So, reminder about this scale is that you are getting points if your child develops aphasia, apraxia, if they develop field cuts, if they have walking difficulty, if they have incontinence or they have a seizure. They get points for these things, and these points add up. So the MFDs, so gene therapy was approved under accelerated approval based on 24-month major MFD 24-month MFD survival, and as I previously stated, 3 gene therapies plus an additional number of patients have developed an MFD. All patients continue to be followed on long-term follow-up study. And again, here are the MFDs. So it's loss of communication, cortical blindness, tube feeding, wheelchair, no voluntary movement, or total incontinence. And Christy had a much more detailed timeline than I do. Mine looks very simplistic compared to hers, but 102 trial was started in 2013. In 2019, the 104 trial was started. There was a hold placed on the program in 2021. In June of 2022, Cellular Tissue and Gene Therapies Advisory Committee discussed ELICell. And then there was FDA accelerated approval for Skysona in September of 2022. And all patients on study are rolled over into the long-term follow-up study since it was started. So what's the point of all this? Well, data changes over time. So this is just an artistic representation of data points. We continue to learn about the safety and efficacy of treatments over time. And so as time goes on, the patterns of data might change. So it's important to remember that data changes rapidly, and we always want the most current information. So if I just self-calculate what's happening with many of the patients, there are 67 patients who've been treated with gene therapy. 3 developed MDS and went to second transplant. 2 had less score progression and went to second transplant, and 1 had autologous recovery and went to second transplant. So that's 6 out of 67, which is a treatment failure rate of about 10%. That number is really hard to find anywhere in the public domain or in the forum, and that's just me going through the data that's out there. So dilemmas. So this is where it gets difficult. Some parents and community members appropriately express frustration about undisclosed gene therapy data and tactics used to manipulate data. And this is what the parents are saying. Families, they want and deserve access to real-time data about gene therapy. And seeing this word undisclosed, it's very unsatisfying, at least in the experiences I have with families. I've heard feedback that Bluebird Bio and the physicians, and this includes myself, can come across as evasive and disingenuous when giving talks, just like this one. So, part 2 of the dilemma, Bluebird Bio has primary control over the data disclosure. In January 2023, my center received safety notification from the Bluebird Bio Data Monitoring Committee expressing risk-benefit concerns, that is, progression and persistent oligoclonality. That's the blood marker for MDS. And these have occurred since June of 2022. Some patients received a notification as well. So despite this, it remains unclear to me, despite my best efforts, is what data can be discussed in public. And for us, we receive this data, we then submit it to our IRB, who says, you need to write a letter to your patients and disclose this to them. So those of you that follow Minnesota probably got a letter. And Christy asked you last night if your institution did the same thing or how it was working for you guys.
So I think, as you say, every institutional review board for studies handles things differently. And so our IRB doesn't, for some things, when there's the MDS, we all contacted, you I'm sure did the same, contacted families individually, by emails, by calls, by lots of different ways. For anything that we get, we often will have that done as a reconsent rather than a letter, depending on the severity of it. So working through every different piece. So I meet with all the families when they come in. We go through the data. So I think families get the information as we get it, but in different formats, which can be challenging.
Right. So we do both. We send them a letter/email, and we reconsent them. And so that's just how we've done it. All right. More on risk-benefit. So now we're going to jump into behavioral economics. And this is important because it's on how you make decisions. So let's say, Ali, you have $1,000. And then I allow you to pick one of these 2 options. Option A, I'll give you a quarter. If it lands heads, you'll get another 1,000. If it's tails, you'll get 0. Or option B, guaranteed $500. Do you know which one you'd pick? Yeah. You're a risk taker. So you would pick A. How many people would pick A? One. Okay. How many people would pick B? A lot of people. Ali would pick A. He's a risk taker as well. Most people in economics pick B, and that's because most people will take a lesser gain when there's a guarantee involved and are risk averse. And so again, this comes from economic theory. Let's change the paradigm around. Now you have $2,000. You can pick A or B. So with A, you get a quarter. You flip it. Heads, you lose 1,000. Tails, you lose nothing. Option B, guaranteed loss, $500. So how many people would pick option B, the guaranteed loss? That's one. How many would pick A? Take your chances. All right, I think I would pick B. Well, in economic theory, what do people pick? They actually pick A. Why? Because when you're faced with a guaranteed loss, you accept higher risk. You are apt to behave in a more risky manner when you're faced with a loss. And this is important for decision making for medical treatment as well. So risk benefit, and of course, Christy beat me to it with the scale. This is often how we do this. We talk about benefit, the good things, the benefits of a therapy, or the risks, the probability of harm or injury to a therapy. Well, there's a lot of ways you could weigh these. Benefits of allo, risks of allo, benefits of gene therapy, risks of gene therapy, benefits of allo, risks of gene therapy, and all the different permutations. So each family and physician has to kind of figure this out. The next concept is really this framing effect, which is how the physician frames the therapies. So the choices are influenced by the way they're framed through different words, settings, and situations. I can talk about the chance of GVHD and the chance of MDS under allo and gene therapy. Those are both negative considerations. I can talk about 0 chance of MDS and 0 chance of GVHD under each of these. Those are both positive considerations. I can also spin this differently and talk about the chance of GVHD for allo and no chance of GVHD in gene therapy, which pits a negative consideration against a positive consideration. And then finally, we can talk about no chance of MDS in the allo setting versus a chance of MDS in the gene therapy, pitting a positive consideration against the negative consideration. So how you frame this whole situation is very important. Relativity. So here's what this means. If I'm in Minnesota and it's -10 on a Tuesday, and then Wednesday's forecast is for 40 degrees, I will be outside in a t-shirt because it's so warm out. I may be shoveling snow or doing something, but it's great. Like we actually do this. Alternatively, my colleagues like Keith, if it's 90 degrees on Tuesday and the forecast is for 40 degrees the next day, he'll probably have a coat. I don't know. He may just collapse because it's so cold. And I'm out shoveling snow in a t-shirt. So the point is the opinions really depend on your starting point and how you frame things and where are you beginning with the patient. And that's the next slide. All the patients start at a different spot. LES scores could be 1, they could be 4, 7, 10, maybe up to 14. NFS is generally 0, 1, 2. I didn't put 3 up here. Often patients with a 3 don't come to transplant. And then you got the donors, 6 of 8, 7 of 8, 8 of 8. And then you got the sources, that's not on here. And then you got everything else that doesn't fit in the bubble. Not to mention that giant HLA report that we just went through. So we always have to think about the starting point when we discuss transplant options and possible outcomes. Okay, so what do you see on this slide? How many people see a duck? And how many people see a rabbit? So a few, or maybe you see both. So it's all about perception and how you perceive these risks and benefits. Same kind of drill. Is it a 6 or is it a 9? Kind of depends on how you look at it. So again, it's about how families, maybe the physician perceives these risks. So for some families, MDS is not a big deal, and they ascribe it as a small risk. Some families are like, I want to avoid MDS at any chance at all costs, and I won't do anything else. So for them, it's a big risk. We talked about gene correction. For that, for some families, it's really important that every gene is fixed in the infusion. For other families, it doesn't matter so much. There's some data to suggest that you gain an extra point or two in your LESS score in the gene therapy setting after transplant in comparison to allotransplant. That may be very important to families, that extra point or two. Some families have heard about GVHD, they've talked to friends they read about online. They want to avoid that at all costs, and it's a huge deal for them. Other families are less concerned about the risk of GVHD. So how do you put it all together? Well, using the scale, if a gene correction and no MDS are really important and the risk of GVHD and graft failure are less important to you, you're in favor of allotransplant because you think those benefits are better for you and that's the right choice for you. Alternatively, if GVHD is a big problem and very scary and you just need to avoid it and you don't want that graft failure risk and you're less concerned about gene correction and no MDS, that's not important to you, then maybe allo's too risky for you as a family and it's not the right choice. On the gene therapy side, perhaps shorter recovery time, no GVHD are really important to you, while the LESS score progression, the imperfect gene correction, and that MDS risk, maybe that's just not as important to you. And so gene therapy is for you because that's why your scale tips. And then the last permutation is LESS score progression is very important to you, and you're not satisfied with not having all the cells corrected, and you're really scared of MDS because you don't want that second transplant risk. Well, you don't care so much about the GVHD, and allo has a little bit longer recovery time. Maybe those risks of gene therapy are too much, and maybe allo's your better option. And then finally, the scale actually can be changed. So you can actually block the tipping of the scale. And these are blocks symbolically, but your insurance company may say, no, you can't have this, you have to have this. So you can just throw the scale out the window then. Your doctor may skew this one way or the other based on personal preference. That's not what we're supposed to do, but again, depends on framing, depends on the situation. Parents or guardians all have opinions for each of these things. And then I can't understate the impact of social media as we have to deal with it every day. Everybody has an opinion and they let you know about it, usually several times during the day. So, but it plays a role, so it tips the scale. So in conclusion, transplant is complicated. The risk benefit is not straightforward. It really depends on the question being asked and how it's framed. Context matters. There are lots of variables that influence this decision-making process. There's no universal algorithm for one size fits all. The risk-benefit will change as we learn more about gene therapy. And I think we need to access safety data in real time. At least that's what I try to do for my patients. And you should always seek expert opinions. So this is my contact information. Most of you know it already. You can contact me anytime. And thank you to Elisa and Miranda. Thank you to the ALD community, especially the boys and the families. And then, of course, everyone who made gene therapy clinical trials and the FDA approval process possible. Thank you.
Hello? Okay. Thank you both for the presentation. I actually had a couple of, so my first comment, I guess, is that bone marrow transplant is not accessible to every family if there's not a good donor match. So that's something we have to take into account to say, gene therapy, we were so grateful for that because not every family can have a bone marrow transplant. So that's number one. And then Number two, I've spoken to some families that have had BMT and then later in life their child has developed cancer. Can you talk about that a little bit and what the percentages are there? Because there was no mention of that at all.
Yeah, I can't.
Oh, you can't?
No.
Oh, okay.
Fortunately, on the allo side, everything's disclosed. Like it's all published. So those rates are all published.
But you didn't discuss that, so I was just curious because that would be taken
Right.
into account when you're talking about a risk benefit
All right.
for both.
So for ALD, I don't know any. So in my cohort, that would be 0. And then I would move on to different types of diseases we treated with are treated with transplants. So are you talking about ALD specifically?
ALD specific.
Yeah.
I know of at least 2 families that their boys had bone marrow transplant and then they had cancer years later.
Yeah.
We're gonna have a hard time with the height situation here. I needed bigger heels today. So it's a really important question. And so the distinction is sort of how you develop cancer, or your risk, I should say, for cancer after these different therapies. And so we talked about what we know about gene therapy at this point. But for allotransplant, chemotherapy, busulfan, cyclophosphamide, and just to acknowledge that those drugs are also used, in gene therapy, and depending on what we use commercially, can impact healthy cells as well as all of the cells, basically. And so if you take everyone across the board who gets an allotransplant, there's somewhere between a 1% and 3% risk of developing those over a lifetime. And that risk increases the longer you live. And so sometimes the data can be tricky because you'll see, as you get older, you have a much higher risk. And that's because as all of us age, you have a higher risk of cancers. And so the way we try to look at it, and one of my other hats is sort of long-term follow-up of patients, not just with ALD, but others, is sort of a relative risk to how likely you would be to get cancer, say, if you were 15 years old and you had an allotransplant versus someone who didn't. And so that risk is higher for anyone who's had a transplant. But what's tricky, and this is where we in the ALD community need more information, is that most of those studies of long-term follow-up are done in kids who've had transplants for other reasons. So kids who've had transplants for leukemias, for lymphomas. And so I think we've all advocated that we need to understand long-term outcomes and risks in ALD better because they're not the same as someone who's had that cancer. So the risk is there. The potential for that risk is absolutely there just by virtue of chemotherapy. And then there are other longer-term sort of malignancy risks. If you've had bad chronic graft-versus-host disease of your skin or other places, higher risks of oral cancers or skin cancers later on. Just for the allo world, also, none of us use radiation, which is associated with different kinds of risks, so just to say that. But yes, allotransplant, transplant by itself can increase that risk.
And then I had one other question. So for us, and this was over 10 years ago, but our hardest decision as a family was to decide which chemo regimen to go with. So we were in Minnesota and Duke, and they had very conflicting, which all made sense when I asked all the questions. And I just heard you both say that there is not a consensus on the chemo regimen. So is there any discussion to come up with a consensus? Because I think that's really hard for the families when you have no idea, right? And you ask all the right questions and the answers all make sense. It's kind of like throwing a coin up in the air and saying, I'm going to pick this one. So
Yeah, and I never comment on other people's regimens because I don't know how they got to where they got. I don't know why they use what they use. I can only say our regimen was built specifically for ALD based on hundreds of boys coming through and getting transplanted and changing the drugs about every 5 years to idealize the outcome till we can get basically to the perfect outcome, 100% survival, no progression. We're not there yet, but we're better this time than 5 years ago, and that was better than the 10 years prior. And so I can't tell you what other people are doing or why they're doing it. Sometimes it doesn't make sense what they're doing and why they're doing it. Some centers just use their leukemia protocol. They just say, well, it's a transplant, so we'll just put them through the leukemia protocol. We don't do that, and then there could be a lot of other permutations.
I mean, but is there any discussion in the community with everyone doing gene therapy and bone marrow transplant to agree on a consensus for that chemo regimen?
There's discussion, but do transplants ever agree? Do transplanters agree on stuff? I don't think they do agree. They're human at the end of the day. And it's hard to put into words. Like, we think our regimen is the ideal regimen. And to offer something else would be a step down in care. That's where we stand on it. So we won't do that. I don't know what other places are thinking or doing as far as adopting different regimens.
And I think one thing that we all agree on is what the backbone chemotherapy is. The drug busulfan is incredibly important in ALD and related diseases. And so it's true, we don't have the consensus, and that's one of the things that is helpful about studies, that everyone gets the same thing. But I think it is something that as a community we need to hear and to think about and to talk, because I think Troy and I once had a very casual conversation about this, because how in the real world are we going to compare outcomes, if we're not all doing the same things? And so I think those are conversations that all of us need to be open to having. Sure.
So I was one of the parents that was an advocate before the FDA for the approval of gene therapy. And after our family went through transplant, have found a lot of meaning in supporting other families, and just seeing the anguish of those families that have absolutely no other option was the largest impetus for me to testify. And I think we all agree for them that it's really a no-brainer. But for these other families for whom the situation, the waters are muddied somewhat, there's a lot of different options before them. I can tell you straightforward how truly excruciating that decision is. And when I testified before the FDA, I think my exact words were, parents must, with full understanding of the risks involved, have choice. And at the time of our transplant, we had all the risks in front of us in graphic detail, and I was grateful for that information. It was hard to hear, but it empowered my husband and myself to make the very best decision that we could for our child. As a parent in the ALD community, I have a large concern right now. I try and support other families in their individual journeys, and I can tell you right now, Dr. Lund spoke of social media in some of the groups right now. Some patients are getting these letters that are in the follow-up groups that there is safety data to be disclosed, others are not. And in my view, that's leaving these patients open to a lot of interpretation, and there's going to be misinformation. They're concerned because they don't know where they stand, and then there's all the new families that are coming forward that are reading this, who are going to be placed in this situation, possibly in the very near future, of having to make this choice for themselves. So there was talk of, it's different with what center discloses what. Is there not an obligation from Bluebird to ensure that all patients receive the exact same disclosure?
So I think maybe I misspoke with that. So all the patients, so there's an obligation that when new information comes, every family who's enrolled and is treated gets that information. And I think the difference is how different they get that. It's whether it's done with an informed consent document or a letter or a call or some combination of all of those things. And when there's important safety data, I can speak for our center. I know we've heard Troy, when there's important safety data, that is done usually by multiple different ways. So there's always an informed consent document, but if you're not coming back to the center for 6 months, you're not going to wait that long to get important information. So I can speak just for example about the MDS data. We did call every single patient. We did send letters. We sent multiple ones, emails, and tried to do that appropriately in as many languages as we can. So yeah, I think you're absolutely right that families who've received therapy, families who haven't, people who are thinking about this need to understand what's happening, the good and the bad, and the unknown.
Yeah. So great discussion, and I think we break this down into individual items that we're putting on scales, but really the question is much larger, and I think for the most part, I would say I would want a center to practice according to their experience. And there are many factors that go into choices, right? It's not just I don't think it's easy to compare handling and experience of different regimens across different centers. So I think sometimes we simplify things, and we say it's a choice of one chemotherapy or it's these individual items, but it's this discourse and the way we talk about it to families I think that can enhance an understanding of trust. And I think there's a real problem if we start saying, well, different centers do different things different ways. There must be something that they're keeping secret. And I think we all don't know what is happening at other centers as well as we know what's happening at our own center, right? And that's not necessarily a question of not disclosing things. It's a question of our own experience being closer to us. Now, they're different, and so I just think the choice of words and the way we talk about this as a community, right, is important, which is to say one should, over time, disclose as much as one can, but one also has to understand that it's probably hard to describe what things mean and find the right choice. I remember, Troy, we were on a call together trying to think, what are the right words to use to describe myelodysplastic syndrome, right? And it took us a few weeks to actually find the right words and say, what can we agree upon? And what does it mean, particularly as you didn't see what was evolving over time, right? And so as we're stuck in time with incomplete information and we're all grappling with uncertainty, how do we deal with that, and how do we approach that in a way that we build trust and allow these new families that are coming to new diagnoses to not feel completely lost? I think that's the more important question, because I think having options in the end is a good thing. For decades we were dealing with families that had no options at all, and now finally we're at a place where there are options. And now we're sort of, making that itself a problem. And so I guess I would it's a plea to step back and just point to more things being in common between these different regimens than separate.
And maybe one thing just to add to that, and this isn't quite what you were commenting on, but I think, just so everyone knows, like all of our medical centers, all of our transplant centers, we all know each other, we all learn from each other, we all respect each other, and there's excellent care wherever. And I think one of the most important things is that you have faith and relationships and confidence with your providers. And so if you're trying different places, sometimes it's your gut feeling that, maybe, whichever center it is happens to fit, but you're going to get excellent care if you are at any of these centers. And I truly believe that.
So I absolutely agree with Dr. Eichler about the fact that there need to be options and that the lack of options that have existed for ALD patients. I just know for myself, making this decision and how excruciating it was, I wanted every piece of information I could have. And so when I hear the word undisclosed data, is there any information on what the parameters are surrounding that as to when this data is going to be made available so that patients can make this choice? Because it is a choice, and this is going to affect their son for their entire life, and I think they should have absolute access to absolutely everything.
Go ahead, Floria. What is your answer to that?
Sorry, and I'm not speaking for Bluebird, but I'm speaking for the trial consortium and investigators. So there are different ways that things get disclosed, okay? And the first level of disclosure is often at meetings, and the myelodysplastic syndrome has been disclosed at the American Society of Gene Cell Therapy, and David Williams has given a talk about that, and those things can be accessed. And then, I think it's always a question of data cutoffs and when things can be spoken about and given full review so that not further uncertainty is and distrust is created, because it's a matter of revealing as much as one can with the knowledge you have in hand at the time. And so I think all of this, I hope years from now we look back and we say, this was actually a good thing because we all learned to talk about uncertainty. And I think this has made transplant better because Troy is talking about disclosing all information, which is great. So I think the transplant field is also benefiting from this, and this is something we didn't anticipate as a benefit from gene therapy. So we're asking questions about long-term follow-up. We're asking questions about what's happened to patients over the years, side effects, and all of this is going to make things better for the field as children and families are going through difficult decisions. So I see this as more of a glass half full. I understand it can be seen otherwise.
And I think just the granularity too, when someone comes for the consent, I know those meetings you have and have been there talking to families about which therapy and how you choose. And we do, all of us, commit to giving as much detailed, sort of granular information as exists. And so, when you're having, hopefully, I hope that none of you have to have conversations with Troy or myself, but if you do, we will give you every piece of information that is available and what's out there and what we know. And as we get new information, we share that as well. Sorry. Go ahead.
And I would say, Florian, there is some discourse between the techniques, and it's because the families feel they're different, and they are different. And so when we break them apart, it's human nature to compartmentalize. That's how we make decisions. We don't make big decisions in an ethos and in a grand way. We usually break it down to small things. And I think this decision-making process, that's actually how it works, because that's what families are bringing to the table. So I'm not making that up. That's what the families bring in. And so they're asking these questions. I think they're very good. The families are very knowledgeable about this process.
There are some questions on Zoom I just want to make sure that we get to before we have to break for lunch. Has any child progressed with the disease in ALD 102 or ALD 104 after 24 months?
Florian, what's the answer to that? Or
Go ahead, Florian. No, go ahead. It's fine.
You're talking about neurological progression, I imagine, or
I would think so. It doesn't specify, but
yeah. So in ALD 102, I think Christy, correct me if I'm wrong. I think 34 patients or something around there. Don't quote me on exact numbers, but I think there were at least 3 that had neurologic progression, and some of this data is still in the process of being finalized and put into a manuscript. So yes, it does occur as similar to a conventional bone marrow transplantation. There is progression, particularly in the first year or 2 after a cell-based procedure, as cells are making their way from bone marrow to blood and blood to brain.
is there any treatment that can prevent brain lesions and NFS progression during and after the traumatic stem cell transplantation process?
Maybe the N-acetylcysteine.
yeah, it's a tough one. I mean, there's no proven medical therapy. We use N-acetylcysteine in our regimens because we show in cells in mice it's a potent antioxidant, and that in one paper we showed that children receiving N-acetylcysteine lived a longer life. But that's where we drew it. Can't say anything about MRIs, can't say anything about neurologic function scale or MFDs. So we've incorporated it based on just that simple data.
And I think there are some things that we can do that don't seem like humongous things, but they actually really matter, that may improve function or at least keep function in the short term. Things like maximizing physical therapy, getting out of bed, rehabilitation therapies, having all of those things. It doesn't stop, brain lesions, but it actually does help people get out of the hospital better, which helps you faster, which can help you recover. One of the things I've noticed is that for patients who have a tough course, you're in the bed for 6 weeks. And so when someone leaves the hospital, are they deconditioned, which is why they're not able to walk, or is this because of ALD? And we think that most of the time it's your deconditioning, but that's anguishing. And some of the things that we expect and consider expected or normal in transplant are really terrifying for families with ALD. So we'll talk about medications that can increase seizure risks, or trying to control fevers or inflammation. And so I think the supportive care, while it doesn't stop the brain progression necessarily, is really important, and what you do around the transplant matters.
Okay, and then before I pass the mic off, this is a personal question. Dr. Duncan, you had talked about the oncogenesis, am I saying that right?
Yes.
And the MDS problem. And there's people out there working to fix it. So as a parent and for peace of mind, is it safe to say that that extends to any rare disease community with the gene therapy option? It has an interest, so there's like a bigger group of people beyond us. And then is the burden falling solely on transplanters? Is there a responsibility for the pharmaceutical companies that already have their product out there? Are they invested in finding a better option? I would just love to get a bigger picture of what's going on.
So this is a bigger, for whenever you use this type of gene therapy where a cell is put in by something else, that is a risk. There are different ways you can design the vehicle, that vector that carries it in, that gives it a different risk or potentially a different risk of the oncogenesis. The challenge is, like everything we've been talking about, there are trade-offs. So maybe you can drive higher expression or more protein if you use one vector versus another. So the first cases of this insertional oncogenesis occurred in children who had immune deficiencies, so something called severe combined immunodeficiencies, and it's happened in multiple different groups in that population. You may have heard in the same time about people who are on other trials with sickle cell or thalassemia developing leukemias, but that's not from this mechanism. That's by something related, we think, probably to those patient populations. So there are people in the gene therapy communities in academic settings, in industry, across the board, who focus solely on this insertional oncogenesis and making that go away. So I think the risk, or what's going to happen in the next years, there are people who are studying ways to get the gene therapy cells in without a vector. So using chemical methods, using physical methods to get the gene in. So I think that is going to be important and emerge. There are people who are designing using the current HIV or other viral vectors to make them safer, trying to target more where those genes are going in. And what Troy and I both talked about, sort of the precision, the gene editing, where you go and correct a certain spot. You can try to, rather than having this semi-random integration, it goes to a certain spot. I think there's responsibility of everyone in this field, whether it's ALD or otherwise, academics, biotech, everyone, to think about this. And I do know that there are some companies who are starting to explore gene editing for ALD, and I think that, to me, is incredibly exciting, because that takes this huge risk, or this monster, sort of the elephant in the room for gene therapy, and would decrease that risk, we think. Although, again, unproven therapies that are new, that are ongoing, so we still have to learn. Everyone has a responsibility, though.
With regard to the disclosures, again, sorry, but I do understand that there's timelines under which things are reported and evaluated. But right now, with what has been disclosed to some members of the community, right now we kind of have this sort of can open worms everywhere kind of thing, because some people receive this information, others does not. There's a lot of skepticism and uncertainty. Given the fact that we have this problem, can there be some collaboration to get this uniform message out to people about this disclosure so that everyone has the same information? They're not going to be left to their own devices, Googling or taking advice on social media that might not be in their best interests.
I think that's an excellent idea. I think, we talk about how we collaborate, we work together all in these trials, but perhaps there are some things that, as the participating centers, we can talk about on calls or things to determine, so it's not so people don't have incomplete information, or there's a difference in timelines. It's never going to be perfect, as you know, but we can try to perhaps be a little bit more similar in our approach, as much as the institutions allow.
Hi, I've been frantically scribbling notes, so please don't consider me looking here at my notes as any ounce of insincerity. I just want to make sure to get all this out. It's awkward for me to sit here, of course, but please know that my silence is out of humility, being so new, and really, it's just such an honor to be in this room and to hear all of this discussion. So thank you for your candor. There are a few things more important to us than earning your trust, as Dr. Eichler said, all of us as providers and just part of this field. So it pains me, to hear that there are concerns over non-disclosure. To your point, we are in a very regulated industry, and there is timing that we have to honor. But I absolutely agree that information is so empowering. And we urge you to seek as much information as you possibly can to weigh this decision very carefully. Gene therapy, as has been said a number of times, it's so complex. It's a very personal decision. And so, we just encourage a participation in registries and the long-term observation studies, so that we can gather as much data as we possibly can, as the field is learning so much so rapidly. my role in patient advocacy on this team, although only 4 weeks in, is to be your advocate, is to take the voice of the community into the organization, and similarly, like I did today, take the voice of the organization to you. We have another person in the room here. We have two birds in the Zoom. But I just wanted to tell you that I'm super grateful for the conversation, and I will take this back to the company.
So in the doctor-patient-parent relationship, there are two sides. And often the patient and parents are of various different education levels and have different awareness of the medical world. So there's the sharing and disclosing, but there also needs to be the confirmation of understanding, or the teach back of the parents, so that you really know that they understand what the options are and what the risks are. I work in healthcare, and often I see patients post-surgery, and the doctors told them stuff before surgery and after surgery, but often I'm retelling the information and they look at me as if they have never heard any of it before. So the timing is important. Often you're talking to parents who are in shock from receiving the news and they're not open to it. There's another parent I've spoken to who, when she found out, she said all she did all day was sit on the floor and cry because she was not ready to process the information. Now, unfortunately, she has to be because her son is ready for transplant. But oftentimes, we don't consider the person sitting across the table from us and how their ability to understand or to process the information affects their decision making. So how is there discussion on how to improve that?
Sorry, I'll jump in, obviously. It's such a critically important point. And as you say, people come to these conversations from various different backgrounds. Some, as you say, with lots of experience in ALD, some who just learned about a disease they had never heard about, and now are hearing about therapies that they've never thought about. And it's incredibly intense. And in the way that at our center, we've tried to approach this is multiple ways. And first, listen to the families. I think one of the other complex layers is that there are patients who don't speak English. And so then we don't even know exactly what is being said through the interpreter, and that's always a little bit concerning. So I think your point about having them teach back to whatever capacity they're able to is really important. So the way that I think many of us approach this is to have more than one conversation, if you can. If time allows, you should always have that. If someone's able to go very quickly to transplant, it's more abbreviated. And as you know, these are never short conversations. But maybe sometimes they can be. There can be let's just talk about one thing, and then we'll talk about another thing, and then redoing that. Because our informed consent documents, they're just not perfect, because they list the thousands of things that can go wrong, and then there's like the one sentence about what can go right, and all of these things that are really challenging. So I think having multiple conversations in this day and age, if you can have a phone call, if you can have Zoom, if your providers are willing to share their email, so when you're up in the middle of the night, if we happen to be up in the middle of the night, shoot me an email. We'll get back to you. We also try to have one of our members of our support team, whether it's a social worker or a psychologist or a family resource worker, join those conversations if we can, and try to gauge what level of support the family is interested in receiving. Because for some families, that's really important, and they can have that conversation after that, and they'll have those pieces. So I think it's always good advice for life, just try and figure out where that person is and work that with some general concepts, though. So the very important advice was in saying, rather than at the end, and I think many of us in medicine say this, do you have any questions, or what questions can I answer, what questions do you have, but maybe just be more, what can I be more clear about, or what don't you understand, or even asking those questions throughout the conversation, not waiting till the end when everyone's exhausted, or here's the one thing. And so I think it's a good point.
No, all good points, and we have a similar approach to that. There's another question.
I'd like to throw one more question at you. You presented a nice summary chart on the gene therapy versus allo on similar populations, and as a parent, I'm sure that has considered this, or those that are thinking about the future, that was very, very strong data. to support potentially gene therapy. But I was wondering, have you subsetted the allo data into, better matched donors, or maybe well matched, and then plotted that summary? Because that could be, I would think you would
Helpful.
want to look at this, but I would expect that to be different if you subsetted the data that way.
It is a really good question. So whether you've used, someone's had a mismatched unrelated donor versus a matched sibling donor versus other things, that has been done. I don't have that slide. That has been publicly available. So if you can give email, we're happy to share that data. The biggest differences, as you can imagine, in outcome are when there's a mismatched unrelated donor compared to a related. I think across the board, when you have a well-matched sibling who doesn't have ALD, that is the survival of the difference is very negligibly different. And so I don't want to misquote the data, but yes, that those subset analyses have been done. There's some limitations on what you can do statistically with that just because of small numbers, but you can still look at that data so we can fractionate and try to figure out what's better for an individual patient. It's a really important question. Thank you.
I don't see any hands raised, and there's no questions in the chat, but there are just 2 comments from members of our family community. One is, I wanted to make a comment regarding deciding whether or not to go through with transplant, and it's that no matter what the data tells you, there is no right choice. And then Connor's mom chimed in to say, I would like to state that with our son not having a single donor match and who hates to take medicine, gene therapy was a heaven sent. Thank you.
I would like to just add something. I'm from a rare disease community, but not yours specifically. We do this work with a lot of organizations. The conversation that's going on here is really good. It's challenging. As Bluebird pointed out, there are financial, SEC, the stock market rules. There are FDA rules. There are researcher contracts. There are institution contracts. But you all are talking about this, and we don't see that in all the other communities. So while you're struggling with it, this is, as Florian and I said, this is a good struggle for you. This is good.
Thank you, Dean.
Thank you. Thank you very much for this opportunity.